So initially, how might we feel? Well, this sure is how I feel right now. A little bit beaten up, battered, a little bit not quite yourself. Like a classic car, shall we say. So a lot of people come to me and say, I don't move as well as I used to. You know, things are not quite as clear. All the drugs that I'm taking making me feel not the same as I was before. And the reason I'm talking about all these things is because all these things have so much to do with our confidence, with how we feel about ourselves, with how others feel about us, and all the things that sort of we have to ask ourselves questions about. How do I top up my lubrication? I kind of need that right now. So if we look back at that car scenario, my engine's less reliable. It's not as automatic as it used to be. Unpredictable things keep happening. I'm overheating, I'm having spasms, my bowels and bladder are doing different things. My brakes don't work too well. I can't tell one noise from another. And well, you know, the question I get from a lot of people is, am I better parked up or not? Not. So previously we know, and we so compare ourselves to how we used to do things before. And as part of the therapy, we move away from that and I help you really think about a new beginning, how to do things differently, how to maybe start again. So we're not just that automatic sometimes. We can't just jump in and drive. And the obstacles, well, before you might have gone around them, now you have to think about them a little bit more. It's okay, even if I don't know where I'm heading. That was okay before. Now it's kind of like, okay, before I leave my front door or hospital, wherever I am, I really need to think about what's next. So much more reliable. The body was so much more reliable. You'd just fuel up and go, wouldn't you? And you got that occasional bump, but you know, you dented, but you reshaped that. And so now that just feels a little bit more difficult sometimes. The other things that limit us are lifestyle factors. Things like, do I overeat? Have I got diabetes? What about my blood pressure? Do I drink too much? Do I smoke too much? What medication am I taking? And how much anxiety am I feeling? These are some of the biggest things that come out for me. Diabetes is a big one with sexual function. So sometimes people think, okay, it might be my spinal cord injury that's causing maybe my loss of lubrication or my erectility issues. But actually, what else could it be? Let's look at the other things that are going on within our body and how we can actually help ourselves maintain the best body we can maintain. So we really need to think about all those other lifestyle factors. We need to think about what medications we're on and how much we need to be on, and we need to be weighing those up all the time, checking in with your hospital, checking in with your GP, which medications do I need to be taking and which ones can I reduce? Because with medication, a lot of the pain medication, what also that's doing is taking away sensation of intimate sensation of feeling, because it reduces what we feel to reduce that pain. So we really have to think about what medication we are on. If we're on medication for depression, we really need to think about the fact that that will have an impact on our desire. So I'm not saying under any circumstances that you come off these drugs. I'm saying consider what you are on and how that might be affecting you, and actually just weighing that up all the time. How much do I need to be on? Is there a better medication I could be taking that will have less side effects? So these are questions that need to be asked. And anxiety, well, that's part of everyday life for most people at some point during the day. So it's about looking at, you know, anxiety. So a lot of the guys that I work with that are spinally injured, they'll constantly be spectatoring. And what I mean by that is they'll constantly be looking at their genitalia to see if is it working? Is it not? What's it doing? I'm not sure if I can feel all of it. So when we start to spectator and when we start to look at our ability or what is happening that we might have expected to happen or we want to happen, that causes anxiety. And when we have anxiety, what happens is all those chemicals flood our system, and the last place the blood wants to be is in your genitalia. And the only place you want, well, not the only place, but one of the main places you want that blood when you want to feel aroused is in your genitalia, even for women. It will help us be more aroused. So we have to think about minimizing our anxiety, and we do that by relaxing. Other things that impact our sexuality and our ability to play, shall we say, our ability to be open and communicate, is the impact of culture. Who are we? Where do we come from? We are all absolutely and utterly unique. So where do we come from? Is it about our religion? Is it about our ethnicity? I'll talk about that in a bit more detail in a second. So often our culture tells us how to behave sexually, how to behave in relationships, and there's a social norm to it. Other things, so the more we are part of a member of two minority groups, I know the less likely we are to be spoken to by other people, so sometimes healthcare professionals, about how our sexuality might work for us. So I remember coming out of hospital and nobody had spoken to me about my sexuality and what I might expect. Nobody had talked to me about my lubrication. Nobody had talked to me about where my catheter sat. Now, I know this is many years ago, in 1996, but what I do find, and this is why this is brilliant that we're able to have this and talk about this, because what I do find is it isn't changing a lot. Yes, it's changing, fantastic, and hence me being here. But it's there is still some stigma that sits with sexuality and disability. So when we look at the more our own culture gangs up on us, we have to make ourselves available to this information. So more often than not, we're the ones with the spinal injury or the partners of that need to be asking those questions, because sometimes our healthcare professionals are too scared to do that. I remember in a hospital one time, even as a psychosexual therapist, I wheeled straight past this older Asian gentleman. I was at the end of my shift and I just thought, and I wheeled straight past him, and then I had a word with myself and said, come on, back, go and talk to him. There's 5 people that you haven't spoken to at the unit today. Go and talk to him. So I did. And oh my word, what an amazing conversation we had. And he said, you are the first person to actually bring up the subject of sex. And sex to me is really important. It is something within my culture that I have to please my wife. And having a spinal cord injury, that's really changed that for me. But I haven't dared ask anyone else because all my staff are female. But you're okay at talking about sex, so that's all right for me. And I referred him out to, because he was more comfortable talking to his consultant. So I spoke to his consultant and referred him out to his consultant in the end. But actually, one person brought up sex with him, which opened the floodgates for him. So it's about permission, isn't it? We've got to, sometimes it's us that has to ask that permission. And any healthcare professionals out there, sometimes it's, it's actually just asking that question in the beginning. And it doesn't have to be a sexual question, because for me, it was mainly about, where does my catheter sit within my body? And having had a diagram of that, then that conversation could have been moved forward with, okay, this is where that sits. Do you want to know about your lubrication? We don't even have to say the word sex. So because then, we as the patient or the client might open up that conversation. So these were my thoughts when I had my injury. My body's not going to do what I want it to do for intimacy to occur. How do I hook my partner now? We think about how partners or how other people, even our friends, which is a little bit difficult at the moment, but hug us. Where do we get those hugs from? And actually those hugs come in from different angles now, which is a really strange thing to start with, because it's how do I balance myself in my chair, or sometimes people are scared of touching a bigger chair because they're frightened of pressing a wrong button and sending you off backwards or wherever. So it's about really thinking and guiding other people about how to touch us now. And that's, that comes from the start, in the beginning, of how do we hug? How do we feel comfortable with that? How do we guide our friends? A lot of my friends will just come at me. And I might topple over backwards in my chair or go, stop. How do we feel about that touch? What do we feel? Because sometimes we might be hypersensitive in some of those areas that are being touched. And we might say to somebody, stop, don't, it really hurts. And they'll never do that again. But actually what we need to think about is our own language. How do we tell people not to be fearful? So my thoughts, and I think this picture illustrates it really well for so many people, is actually, I feel like my body won't do what it used to do for intimacy to occur. And to start breaking down these chains, we can start that really early by asking those questions. Okay. So, as I've said, is my body going to do what it needs to for sex to occur? Will my partner be turned off by my naked body now? That's a really good question. In that, who's the question about? Is that question about what your partner sees and what your partner thinks? Or is that question about you and what you see and what you think? And if that's that question coming to me from a client, I'll work on it. What is it that they see about themselves? And again, as I've just said, it's about the value and the culture, everything about where they've come from. They'll have an effect on how they move forward with that question, I suppose. How can I make sure intimacy, and I just mean sex, is safe without ruining the moment? And again, it's all those things like I just said about hugs, about movement. So I'll talk to my clients about how they move around each other's bodies, even really high level injuries. How do we do this? How do we move around? How do we hit those erotic areas of our body, those areas that can make us feel amazing? I've just been part of a 5-day, say, conference. And you can still access that conference, and you can look at the different workshops on it. And there are so many workshops on touch, on feel, on tantra, on meditation, on all the different things that we can use to enhance how we now fantasize, how we feel about our bodies, how we communicate with a partner. Obviously this is a quickie in this session, so but there is so much information out there. We can put that in the chat box about how to access that, because that's still available for about 27 days. It was available 30 days from the festival. Will I orgasm or ejaculate too quickly, too slowly, or not at all? One of the biggest questions that comes through my door or now onto my screen, pardon the expression. How will I know what to do to turn another person on? If I'm the person that was sort of the mover in the bedroom, so to speak, how do I do that now? How do I get on my knees? And with that, we talk about different practical solutions, as well as actually this is about simmering. Now, I find simmering something that's really interesting. So simmering is about contacting a partner or a lover, or maybe someone you've just met. And that might be about actually, when are we going to meet? Not necessarily for sex. That might be to go out to dinner, whatever that is. It's about playing with each other, I suppose, maybe through text, or just sending those nice messages. How beautiful you look today. Your lips look luscious this morning. Oh, what do you smell of right now? Start being curious and asking questions. And that can last throughout the day. I know, my job's been very busy. And sometimes what I need to do is schedule. So I have to schedule with my partner. So to schedule, if I want to schedule, I'll send him a text during the day. This is what I'm wearing. this is what I, just sort of silly things like that to make it fun. And people will find their own ways. So when we say, how do I know what to do to turn another person on, there are more ways than actions. And I work with a lot of people that use their PAs to help in that situation. So if you are going to look at the Love Abilities Festival, there's a fabulous talk by Andy Walker, who's a C-level injury, and he has an absolutely hilarious talk about how he navigates with his personal assistants to put flowers in different places and to really woo his dates, if you will. So we look at that. What I consider all the time as a sex therapist are social graces. And they are things that make us feel comfortable in social situations. So all our social graces, so I'll look at gender, race, religion, age and ability, class and culture, ethnicity and education, and sexuality and spirituality. All those things underpin who we are intimately and in relationships. So I'll always underpin the work with these. I'll always really think about where that person is within their social graces. And the more comfortable we feel working with social graces, the more comfortable we are to open up. And as a psychosexual therapist, one of the main things as my job is to really, really work with people to be open and to communicate, because we're going to get the best out of the work if people can be open. Sexual identity, and this gives me ways in. So these are my interventions. I will always look at people, what's going on for that person right now. Let's look at the grief and the loss. And this isn't just for the individual. If there is a partner, we will always be looking at this together, if that person wants to do that. So I'll be looking at their loss of less desire and what that's about. Is that about the injury, or is it about something else? Less arousal. Often the arousal is about what's happening internally for that person. So turning themselves off, if you will. Avoidance, because what do we do when we're scared? We avoid. So that's why I talk about keeping people together with, what do you call it, with scheduling. Because if one person stops, and we know this, if one person stops, I suppose in a sexual sense, if one person stops initiating, the other person might stop initiating. And then it becomes this competition, and then it just disappears. So we have to look at that avoidance, and often that avoidance is around fear. You know, one gentleman I was working with who had cancer, his wife had moved out of the bedroom because of what he was going through. Sometimes some of the nights were really difficult for him after he'd had his different medications. So he was really struggling, and she never went back. And he came into clinic and said, I don't think my wife loves me anymore. She's never come back into the bedroom. And when I brought them together as a couple, for her, it was like, he never invited me back. I thought he was happy like that. So we can take things for granted so often, and we catastrophize, don't we? So that's exactly what that is. She catastrophized that he didn't want her back, and he catastrophized that she didn't want him back. So that takes on to the relationship factors and the hypervigilance about safety sometimes. Am I frightened of hurting someone? I remember when I first came out of hospital, and my partner was terrified of laying on top of me because it'd been drummed into us about pressure sores. You know, I was terrified of being, I wanted to be feminine. I was terrified of being feminine, so I wouldn't wear high heels. Now I've got 4 foot plates for all my different shoes, because I want to stay feminine, and that's about my identity. So we look at that fear of more injury and fear of more pain as well, don't we? So all these things have to be considered. So we look at a person feeling quite often that how you are now is going to last forever. And I think that can be scary. Again, I remember coming out of hospital and thinking, gosh, I'm going to be like this forever. I'm always going to need this amount of assistance, this amount of care, this amount of disabled equipment. Until years down the line, I realised half the equipment I could make look better. My bedroom, for instance, didn't need all that equipment in there. My bathroom could be less terrifying. So we need to look at how we feel in our own homes about it. So I used to have a big white shower chair, and now I just have a very stable wicker chair that I would put out in the rain, and it works in the shower, but it matches my shower room and it looks nice and it can be easily moved. So these small adaptations that we can make can have a big impact on how we feel about things, so our stress levels. And but we know that when a partner, sometimes they can feel entirely responsible. If we feel entirely responsible, how does that affect our partner, and vice versa? And we get less sexual satisfaction from that. I love this. Sexual wisdom from Masters and Johnson. Masters and Johnson were at the forefront of sex therapy many years ago, and kind of enabled this to start. A stiff penis does not make a solid relationship, nor does a wet vagina. Absence of sensation does not mean absence of feeling. Inability to move does not mean inability to please. And inability to perform does not mean inability to enjoy. And loss of genitals or genital sensation does not mean loss of sexuality. So if we look at couples, I'll just do my time check. If we look at couples, we need to look at issues around independence and dependence. In a relationship, it changes the dynamics. Our roles might have changed. We often protect our families. So what does that do? That creates barriers. And sometimes even our healthcare professionals can't get in there to help us. When communication is unclear or sparse, we often make our own realities, don't we? So, if we can't get hold of a partner on the phone, and normally we can, what do we do? Where do we go with that thought? I catastrophize quite a lot and bring myself back down to earth. No, he'll be fine. He's probably just working. He's not had a crash with a big lorry. We do this. We need to keep a check on it, especially after trauma. Fear of hurting a partner that I've talked about before limits that touch and affection. And is my partner or family overwhelmed? And am I sharing the relevant information? So I talk to a lot of people about their sexuality, and normally people will ask me questions about function early on, about what they might expect early on. But it's not till 3 or 4 years down the line that they actually start to really think about it and come back to see me quite often. A lot of people will have worked it out for themselves. And some people just go, you know what, I just want more information. And we do avoid hot topics to minimize our distress, don't we? Something somebody mentioned to me: if you told me before my accident in 12 months I'd be having sexual problems, I'd have laughed at you. Lovemaking was brilliant, and even while I was in hospital I really fancied sex. It was just when we got home, the catheter kept leaking. Getting around the house was a pain. I couldn't get out easily. He was tired, I was tired. I felt like a spare part. I could tell things went right, but there never seemed to be the right time to talk about it. I didn't want to put on him anymore. I was more than I was already doing. And to normalize what people say. I did a research project, and a lot of the people were saying, how does it affect my sex life? Well, this lady said, I told him to stop pretty soon after he penetrated me. It was freaking me out. I couldn't feel it. So no, it wasn't a good experience. So when we look back at the social graces, as a sex therapist, I'd look at that and go, okay, what is that about? Where is that coming from? What is that about not being able to feel? Let's look at, and then I'd start to look at what she felt, what they felt, look at positioning, look at movement, to normalize that. If we're going to meet a new partner and then go and mess all over them, well, it's not the best start, is it? So again, I might refer that back into the hospital. Why is this happening to this person? Yes, absolutely. I know sometimes accidents happen, but actually for this person, I'd be investigating what is happening. Is this happening a lot? Can we look at the bowel and bladder situation? Can we look at how that might need to change for this person? I hate feeling that I'm being not raped but being used, just lying there. And I can really associate with that because I had those feelings when I had my injury. So again, that's looking at, what are you thinking about your partner? And are you thinking that because it's that area of your body that you don't feel and that's what you expect? Or so then I'd be looking at their culture and where they came from with that. I certainly hadn't accepted what I'm like. I don't like looking in the mirror. I don't like having photographs taken. I've gained a lot of weight. Absolutely body image here. Body image, confidence. Let's look at psychology. Let's look at maybe referring out to the psychologist for this. But actually, sometimes that in sex therapy, sometimes we'll work with that about really looking at parts of your body that you do like, wearing clothes and looking in the mirror. Sometimes it can be a shock, and I remember it being a shock sometimes when I'd catch a glimpse of myself. I'd feel absolutely normal, if you will, that funny word normal, and I'd wheel past a window and I'd look and go, oh, gosh, that's me. And that took a while. It took a while to get used to me, and feeling sexy, feeling feminine, feeling me again. I'm never going to have a boyfriend again, this lady said. I'm ugly and my body is different. If I don't want to show me, how will I show it to anyone else? That's it for me. So this person had given up at that point. So again, that is really about delving into that and looking at what is okay, maybe teaming them up with some peers that have had good experiences and really looking at, actually, this is what it can be like. Don't give up now. I feel a bit bad for him because if it was under normal circumstances, the lady would get up and clean themselves up, wouldn't she? But if he wants sex with me, he has to clean up the mess afterwards. So we look at that, don't we? And absolutely that's cultural. Absolutely that's how we feel about traditional roles. I should be cleaning up. I'm the female here. So let's look at how those traditional roles have changed in everything. And let's look how, because this person was a high level injury, let's look how that's worked with the PAs, with the carers. Let's look at how the conversations with the PAs and carers need to be had, and how some of that can be shifted, but some of it is ingrained, so it can't. And we need to remember that some of this cultural, some of our cultural things and our religious things will never shift. They are what they are, but we have to look at different ways and different means to move forward that don't intrude on our beliefs and our systems. So it's hard because there's carers in the house, knowing that someone else might hear and be involved, and you can hear people walking up the corridor, and it makes it really awkward. And if that's a reality of life, that's about, for them, boundaries. What are the boundaries with their PAs? How do they manage those boundaries? And I work with PAs and carers quite a lot about managing boundaries within the festival. Working with that has been quite incredible. A lot of people at the festival have had cerebral palsy, and we've been looking at how they do work with their carers. And I've learned all sorts from that as well. We need to look at the law when it comes to that, because we need to look at policy for the carers. We need to look at our own policies. and what we will agree to. So there's a great talk early on. There's a lawyer called Claire de Tan, or Claire de Than, and she works with human rights and sexuality. She has her own invisible disability, shall we say, and she is an incredible lady. So if any of you have got questions about roles and PAs and the law and sex, Claire de Tan is absolutely amazing. Just look her up, and you'll be able to email her directly. She will be there. She's just fantastic. So when you tell somebody, when you do tell somebody something like that, so something like, actually my bowels and my bladder, or and it's quite heartbreaking when you don't hear from them again once you've told them. So you've gone on lots of dates, and then you kind of bring up in a conversation. It's almost like telling someone you've got an STI. And this is how this person felt doing dating. And we had a great discussion about this last week, about devotees and dating, and do we put a picture of ourselves up with our, as a gentleman called it, our apparatus. Do we put a picture of ourselves up with our wheelchairs, with our sticks, whatever they are, first of all on the dating site? And I found that really interesting, because so many people did. And then this guy said, well, people are going to swipe past you and not give you the opportunity then. But if you don't put that picture up first, I mean, obviously people have different opinions. And if you don't, and then you might get devotees as your first people that will contact you. And so, so a devotee is someone that often likes to date people in wheelchairs or with a disability. Often they want the disability to be their own. And I used to say, well, what's the difference in dating blondes or just having, dating people in wheelchairs? Some people have a preference. So it's a really interesting topic. But actually for this person, it was like, obviously she'd had a lot of rejection. And then she had to tell them about her bowels and bladder, and then how was that going to go? So she just felt like, she just had enough. And I say this in a lot of my sessions. One lady said to me in a conference, but it weeds out the jerks. And I thought, well, that's, yeah, I get that. That's pretty amazing. And then a younger lady went, but I'm not ready for the jerks to be weeded out just yet, which made me laugh. So, there's difference everywhere, because we know, I'm T12 complete. I talk to another female who's T12 complete. It's different. So we are all unique, and we have to remember that. So often we can't expect our healthcare professionals to know everything, because we have to give them something of us for them to know. In my opinion, I would guess, because it's really hard to find research on this, that 50% of people with spinal cord injury are sexually active in the first 6 months after discharge. But I would say approximately 35% of those are generally dissatisfied with their first sexual experience. And they are unhappy with their physical functioning and their ability to satisfy a partner, and the lack of pleasure that they feel right now that they're receiving. Most people with spinal cord injury still do not feel that they've mastered their sexual adjustment. And again, I would say that's 50%. They're dissatisfied with sex. And many people at that point just put it to one side. So if you are here today and listening to this, thank you. You are wanting to look at and discover and ask questions. You may already have done that, and you want more information. And in my opinion, a year following discharge, about 70% of people aren't sure who they could talk to and how they could get services related to sexuality, even if they wanted them. And as a result, they don't ask. That's heartbreaking for me. You have this resource. And I've had to swap slides. So, Philippa, could you please put up the information that you have about the services? Are you there right now to be able to? Thank you.
I'm here.
Thank you.
Yeah, we'll get them. We'll share that information, and I can see there's been a few questions as well. So we
Wonderful.
have Pauline's details and that as well to share.
Yeah, so it's Pauline Shields that you can contact, and Philippa will put up how to do that, and that's your sort of sexual way in to ask questions. The things that are mainly discussed, I think we've gone through that to some degree within this. You know, I remember speaking to a lady who was terrified to talk to men, and her values were that it's awful. And most of the staff that she was seeing were male. So when she came into the patient education session and booked an appointment, she was like, "Oh, can I talk to you?" So if the healthcare professionals out there that will be listening to this, please refer these out to Pauline. You know, send Philippa a message, I think, to get people referred out. Always ask the questions. Three's crowd. So we need to really think about our PAs, and I have touched upon that, and I know I'd like to answer some of the questions that have come through. So we know it's difficult with a PA, and that's a whole day's workshop about how we work with our PAs. That's for another time, but it's so important. I've talked about some of the couples that I have worked with, and quickly I'll just run through this case study to give you an idea of how I actually work. 42-year-old man has fallen downstairs at his home and sustained a spinal cord injury from his navel down. He was admitted to the Spinal Injury Centre and underwent 5 months of rehab. As his injury is from T10, his navel down and complete, he was unable to feel any sensation below this area. And as I put at the bottom, just said, every injury is different. It later became apparent that both partners were struggling to cope with the idea that he could not feel as he used to, and they struggled to move as he once did. His wife felt hurt and became critical of her husband. So we were talking about before in that one of those slides that we can throw criticism out, we can protect ourselves, we can push another person away. So this caused him to feel increasingly emasculated, and loss of desire developed in both partners. So the psychosexual approach, that included tailored education. It works with cognitive behavioural therapy, so I give them tasks. To begin with, these are non-genital. These are about sensation and touch and communication and movement. And we look at, and the cognitive part of behavioural therapy is that they go away and do the tasks and they come back and speak to me, and we look at what happened. What are the blocks? Sometimes this is not an easy process. We do look into those blocks and what that is about. For this couple, they explored issues around his masculinity. What did it mean to him to not be able to stand up and hammer just a nail into a wall and put a picture up? What did that mean to their relationships? How had it changed the roles within their relationships? He was getting frustrated telling her how to do things like wire a plug. I should do it like this. Things that were once simple to him, he'd looked after her, and their roles had completely changed. So their intimacy changed. So we looked at the reliance on medication because they had previously tried the PDE5 inhibitors, so the Viagras and Cialis, and how that had been experienced by both partners. So in that, she felt that if he can't feel it, what's the point? And he felt that actually he wanted to penetrate his partner, but it was really difficult because he didn't feel the same about it. He was spectatoring all the time, and there was a lot of anxiety there. So we did a lot of education before we went back to using the PDE5 inhibitors. This is why I think it's so important that people get psychological support before they are given anything to maintain erectility. Asking the questions, what is this about? It's okay to go home and be able to have an erection. but actually how does that feel to both people in that relationship? It's also addressing couples communication, and there's a lot of communication being missed because they were scared to hurt each other. So that was about the adjustment and the loss. What did it do? It allowed the couple to become more comfortable and relax with each other's presence, to begin holding each other again. So if he touched her hand, or she touched his hand in this case, they were both scared that it might lead to sex. So they withheld from each other and stopped touching each other, even affectionately. So we looked at actually, it's okay to do that with no goal orientated movement after that, but communicate about it. So that to help them overcome sort of that awkwardness and the anxiety. And it offers specific strategies to increase feelings of togetherness again, and to help the couple to be able to make decisions about the use of medication at a later stage. I use lots of detail to do with memory, fantasy. We might look at adding mirrors, reading stories, telling me what's going on and looking at the notes, becoming more attuned to other bodily indications of sexual arousal. There are so many. Incorporating other sexual stimulation and exploring the potential of other erotic areas. So no one is ever asked to do undress or do anything sexual in my therapy room, believe me. I don't even want to see photographs of it, thank you. The amount of people go, well, do you want to see a photograph of my penis? No, I don't. I do talking therapy. I leave you to do that bit on your own. No one is asked to do homework that they don't understand the rationale for. Every couple is unique, every person, if it's just one person that I'm working with. It's all about positive outcomes. We don't want to do something again if it's not enjoyable. It's like rebuilding a whole new sex life from the beginning. And we have to be in the right psychological space to do that. And that's why I say often it is 2 or 3 or 4 years later. So it's creative, it's fun. We take anxiety performance, we just take away the performance spotlight. And clients' goals are so varied. Sometimes I might want them swinging from their chandeliers. They just want to have a Sunday morning hug with a cup of tea. So it's always about their goals. Body mapping is something I use all the time. I know we've got not too long left. So body mapping is something that I use all the time. That's about how we get the fun into it, touch and sensation. So thank you. I think we have come a long way, but there's still some way to go. So we all need to stop being curious and asking questions.